We welcome Dr. Karan Dawson, who will be providing an interactive discussion on communicating effectively with older adults. Dr. Dawson obtained her bachelor's and her master's degree in pharmacy and her PhD in speech communication at the University of Washington. She has practiced as a clinical consulting pharmacist in hospital and continuous care settings. Her faculty role at the UW School of Pharmacy has allowed her to establish the Pline Center for Aging and implement innovative pharmacy services at continuous care retirement communities. Unrelated to pharmacy, she was a founding board member of the Center for Chronic Illness, a national nonprofit organization that promotes well-being and decreases isolation for those impacted by chronic illness through support and education. Dr. Dawson is currently a clinical associate professor emerita in the Department of Pharmacy and faculty in the Pline Center for Aging. Although retired, Dr. Dawson continues to teach courses in mind, body, medicine, spirit, self-care, and professional development. The floor is yours.
Well, thank you. I would like to have face-to-face conversation and at least audio. So I just want to invite people to feel comfortable and go ahead and speak up. And if you want to ask a question, please do so. It would be fabulous. And I'm going to provide some opportunities later for you to talk. But first of all, I just wanted to get started with a little background here. As you can see, our talk is supposed to be communicating effectively with older adults. Well, I couldn't come up with an interesting title for a long time because I was just thinking, wow, we communicate effectively all the time. And how are older adults special? Should older adults even be called out as special? Because as my background is I think communication is we do it all the time. It's the most creative thing that we do. And we might do different things for different populations, but to just say it's only going to be about older adults, that's not true. So I also then decided, I have a new title for this presentation. And I'm calling it The Art of Cleaning Windows. And I think that I should tell you why I chose this, because I start every day with a meditation. And I also, in my university courses, always start every class with a meditation and a little centering exercise. And I would like to invite you to join us as we do that. And of course, you have your cameras turned off, so I'll never know. But anyway, I hope that you'll enjoy this. And as you listen to, let's see, can you see this? Can you see this?
Yeah,
You can't.
oh,
okay.
Mm-hmm.
This is the book, and it's called The Book of Awakening, Inviting the Life You Want by Being Present in the Life You Have. And as you think about what we're doing today, we're talking about communication and we're talking about particular audiences. And I think this applies to both us and them and the whole notion of communication. So this book chapter is called The Ordinary Art. And the subtitle is, Before Fixing What You're Looking At, Check What You're Looking Through. And then Mark Nepo goes on to say, it was a beautiful sun-filled day. I had driven 300 miles to see her. She was 94 and had been in the one room for close to 8 months. I was her firstborn grandson, and she was so happy to see me. But after catching up, we sat in silence on the edge of her bed. And finally, she said, as she complained about how gray the day was, I realized then that her one window hadn't been cleaned in almost a year. When I said this, she chuckled, as only someone 94 can, and uttered with her Russian accent, got a dirty eye, see a dirty world. It is the same with our minds and hearts, for our very self is the one window we have into this life. And so often we suffer the mood of a dirty window, believing the brilliant world is gray. Perhaps the purpose of authentic relationship is to help each other keep our minds and our hearts clear. Perhaps inner work is the ordinary art of cleaning windows, washing them, so the day is fully the day. So thinking about how that might apply to what you do with others as you do your work, let's just take a minute and have a deep breath and let it in and let it out. Just breathe. Feel yourself in the comfort of your chair or your room, wherever you are. Feel that you are there. And as you breathe in, allow the breath to wash ideas from your mind, ideas that don't serve you. Just let them go. You can pick them up later, like your to-do list. You can pick that up later. Now breathing in again, just breathe evenly and allow the breath to wash the film from your heart. And what that film means, to me anyway, is that our heart is symbolic of our emotional selves. And our emotions are a wonderful source of information. They're a great set of data, but sometimes they can get in the way. So let's just let those go. Breathe them away. And finally, let's take a last deep breath and allow our breath to wash conclusions from our eyes. The conclusions can be whatever you think they are, but let's just let them go and start fresh and have clean windows. Okay. Well, how are you doing? So what we're doing now is I'm just going to go over our agenda for today. And we just did a little preparation. A lot of people, when they are getting ready to do something, they take a big deep breath and let it out and kind of clean their mind space for the next task. And so what we just did was we cleaned our mind to do this next big task, which I'm going to be asking you to participate and to talk, even if I can't see you. I'm also going to ask you to set an intention with your clean slate. What is your intention for being here? What do you want out of this time that we have together? The next thing is we're going to ask you to take that intention and we'll do a thing called a breakout room.
I
I
didn't
don't
miss
know how
anything.
many people are
Just
aware
doing this
of
whole meditation thing.
breakout rooms. But Angela's going to take care of that. And I wanted to thank Angela and Sarah and Anita for making this possible for us to try this way of being interactive at a distance. So if you like that little meditation, here's the citation, and you can use that in the future. This is a window piece of art that I lifted off the internet. I found it. I was able to find the attribution for it. And here's the artist official website. So enjoy this window and the whole idea of what we're going to be doing today. Now, next, I want to talk to you about the situation. And I'm sorry, background, the background. And so in the breakout rooms that you'll be assigned, you can introduce yourselves and just kind of get to know some other participants of this program. I think that's one thing I always enjoy doing when I attend a Zoom, is to be able to find out something about the other people that are in the room. And you can introduce yourself however you want to. You can talk about your name or your organization or your role or something else that you find that you like to do. But just kind of get to know each other a little bit as you are comfortable doing that. Once that you kind of have a little bit of a community that you've developed, this is where your intention comes in. So what I would like for you to do is to brainstorm what you want to achieve as a result of coming to this meeting. So that might be your intention of what you want to learn, what your expectations are. And just talk about that. And let's keep kind of a way of keeping track of that, because this becomes the needs assessment that I needed to see how best to focus this conversation with you. All right, so that's what you're going to be doing in your space, in your breakout room. And before you leave, would you please make a list, one or two words of the different expectations or needs. So if you you came here expecting to have language to use for someone who is crying or to prevent anger or that kind of thing, or is it something else? Is how do you do an intake, or I don't know. I have no idea. And that's why it's important for you to tell me what it is. And then you're going to come back to the main room that we are in right now and share your lists. Okay. All right. Well, are there any questions or concerns? Not seen any. Angel, would you put us in our breakout rooms? Oh, this is kind of entertaining, isn't it? Our own art project.
Karan, would you like people to keep putting their comments in, or would you like to move forward in the
I
presentation?
think it's time to move forward.
Okay, sounds great.
And we want to save this. This is a lovely piece of art that community created. So thank you all for doing this. Okay, so we created a word cloud. I just wonder how many people had ever done that before. Okay, so I hope that was kind of a fun kind of little community building activity. And so this is a set of, you're going to go back to your original breakout rooms. And now that you know each other, you can bring, I hope, the freedom of just being who you are and your experience and your thoughts to a case. And the case, not knowing exactly what your backgrounds are or what your needs are, the case is sort of very bare bones and is for you to just kind of fill in the gaps if the situation doesn't quite fit what you do, kind of tweak it enough so that you can respond to, okay, here's a situation. What's going on here? What's happening? And then consider, okay, what communication tools or activities or can I use to move this situation forward? There's a little bit of a block there. Does that make sense to folks? And I can't see if people are raising their hands or anything. So what we've done is we are sending you back into your rooms, and this isn't quite accurate right here. You'll see that the rooms are listed case 1A, 1B, 2A, and 2B. And you'll stay in those particular rooms. We will not combine you as this suggests. And when you're in your rooms, we'll take about 10 minutes and just kind of look at that patient or that person from your own perspective and consider that you are responsible for helping that individual in whatever way that you normally would, with it be on the phone or whatever. And the idea here is that you will have different perspectives, and that's okay. Share them, because that's how we wash our windows. We learn more and more and remove more and more film between us and the other person, so that we can really try and be our authentic self and help our patients or our clients or whoever we're working with to feel valued for their authentic self as well. Okay, so are there any questions? Well, then let's let everybody go back into their rooms with their particular case. This is an example of a test case, and you can see it's pretty bare bones. It's a little description. It's a male who's 85 years old, weighs 140 pounds. We know that he takes a couple medications for his hypertension, and he's taking acetaminophen for pain. His blood pressure is 90/60. Now, that might not mean something to everybody, but that's okay. There's probably somebody in your room who can tell you. His physician has suggested a trial steroid injection to his knee for his pain. You know that. So now you can be starting to think, okay, what is going on? What is his need? What is the physician trying to do? And this person, Mr. AB, is a very loud speaker, and he wants a prescription for a shoe insert that he has seen advertised, and he's got the advertisement with him, and he's showing you, whatever your role is, the ad, and he really wants this. He wants a prescription for it. because they cost $2,000 and they're not covered by Medicare. And when you see the picture of this thing that he's going to wear on in his shoe, it's going to cause, looks like, this could really throw his balance off. And then that would increase his risk for falls. And oh dear. So you foresee a problem with these shoe inserts, and you're trying to explain that to him. And he just kind of just nods and just keeps saying in his very loud voice, I want these shoe inserts. And he appears frustrated to you. And you just, so you're worried about all these things. How are you going to handle this situation? Okay, now there'll be a different situation for each room. This was only the teaser of what it'll be like. And there's a little reminders of what we want to do. And if you feel like it, you can be really creative and you can do a little skit to come when we come back to the main room and say, okay, this is what we saw happening, and here's a little skit that shows you what we think could have been done, or what, ooh, don't make it worse. Here's what not to do. Okay. Well, welcome back, everyone. I'm really curious to see what kind of things that you saw on these cases. So could we just very briefly report back? So for those of you who were in case 1A, what did you see? And I'm going to take my slides back so that everybody can see what 1A was about. Could you tell us something that you noticed in this case?
Part of what we all seem to be saying was something along the lines of, wow, that's a sentence and a half that doesn't really tell us much about this gentleman and what he actually gets or doesn't get and why or why not. So probably something like, hey, tell me more about what's your understanding, what's your experience of this with the diabetes and the lifestyle and things folks keep talking with you about or talking at you about, to get a better sense of then how to proceed. What's everything from culture to education level to access to food, to just, there's a whole lot there that we don't know that would matter.
Yeah, and so you're trying to pare it down to see what does matter and what you should address with him, rather than trying to argue, well, this is not a good idea.
Right.
It's costly. So these kind of encounters, it really fits the word cloud, is that you have to figure out how you can go to the first step when you've been dumped into a later step. And so the first step is finding out what's important to that person. So thank you very much. Anyone else have any comments? Okay, let's go to case 1B, that group.
Okay, so we had similar type of things that we brought up. A lot of questions. We weren't sure of what was going on. Similar kind of thoughts about who he is, where he might be. And in our case, he's 30 years older. And we questioned and wondered, does he have a hearing loss, right? Is he just shaking his head? Yeah. And, he doesn't even hear what you're saying, but
Yeah.
He doesn't want to look foolish. So he just goes along with whatever. But assuming that he still has some hearing and we can communicate with them, we wanted to approach it from okay, what matters to you? What do you want to get out of the rest of your life, and how can we be a part of that? And we had a wonderful social worker in our group, and she wanted to be strength-based and find out, like, well, what have you been good at, right? Whether it was your career or things that you're proud of, and how can we adapt that to this part of your life?
So that's a very positive moving forward. And so thank you for sharing that. Okay, let's go to 2A, the group who had case 2A. This is a different issue. Is there anyone from group 2A, case 2A? Then I will go to the next case. And let's see, it's Ivan. You and your group noticed that, you know, the difference of age really only made a little bit different in what you thought maybe one of the underlying problems was, which maybe he had a hearing loss. And but otherwise your approach was very much the same as with a younger person. So I think that's very encouraging, is that I think about all of the skills that you all have. And what we're doing here is you're just affirming that you have these skills and that you can use them, whether a lot of them, no matter what the patient's age is or their culture is. Okay, case 2B. In the interest of time, I would just take over. And this one again is the same situation here. We had an older person and a younger person, and he has hypertension. And so I'm just thinking, if we use the model that Ivan presented, what's important to him? He doesn't like taking medicines. So you kind of wonder, did anybody ever talk to him about that previously? And what he's wearing hearing aids. So, and there's a lot of questions here that we would have. And with respect to hearing aids, you know, a lot of people just up the volume of their voice. And then that can sound quite aggressive when we're speaking more loudly than we normally would. So, and then with someone who has hearing aids, it can amplify, as you know, everything. And so a person can feel even more threatened with a higher volume. So you've probably heard this, is that you drop the tone of your voice down, the quality of your voice. You go into the lower registers, because it's the upper registers that people have more difficulty hearing. And the other thing that for people with hearing aids is you want to really consider the pace at which you're speaking. It can be really hard to hear rapid talk. So pay attention to the speed in which you are speaking. Slow down a little bit. But that gets us to the notion is we do not want to go into the idea of elder speak, which is we start oversimplifying what we're saying, and we don't recognize that people still may be totally cognitive intact. It's just hard to hear what you're saying. So enunciate, and I think everybody knows that. The fact that he incompletely filled out the intake sheet, that's kind of interesting too, because why? Is it maybe he can't see? Maybe has a tremor? Maybe he has poor health literacy, has low health literacy, and he can't read. So all these are things that could be screened for in advance before your patient or your client sees you. So these are just some ideas that you really came up with, and you did a great job. And what you just did was you identify the tools that you already have. You already have a lot of tools in your pocket. And so if we think about those tools, these are the ones that are recommended in the literature, and asking open-ended questions. And I heard that was something that folks did. Listening in a compassionate way. And so that's one, is that open-ended questions, but it's also reflecting back to the individual that you're hearing them. Oh, So you're very interested in this shoe product. Well, and then you can move on and build on that, which I heard that other group also kind of went that direction. I didn't hear any stereotyping, but it can be very subtle and we don't even know it sometimes. But I think in your group that you're very aware of that. The whole notion of shared decision making came up when you wanted to talk to him, to the patient, one of the patients about his shoes choices. One of the things I didn't hear was offering choices, but I think that that's probably what you do too. The person who doesn't like to take medications, for example, well, tell me about that. What is it about the medication? Follow up and find out what it is about taking medication. There might be a choice of that are available. Maybe there's a combination product or something that would be available. We mentioned elder speak. We didn't talk about monitoring and controlling our own nonverbals, but I heard you look very talking about observing that in your patients. This one, I had never run across this one before. For older adults, you think they might not be able to hear, or even if they can, to be, you usually say eye level, but here it's lip level. And I'm thinking that that might have something to do with the motor neurons, which is an interesting aspect of life. I'll skip that. The other thing here is attending to sentence structure. As I listen to your sentence structures, they seem to be more direct. And one of the cues that might be helpful to you for certain populations is sometimes it's better to use shorter sentences, but be careful about clipping them too short so that the person feels that you're dumbing down everything to them. Rather, what you want to do is say the important thing first and then any other thing. You want to, for example, you don't want to say, well, if you want to get better, you need to take this medication every day. No, turn it around. This would be called going to a right clause sentence. So you start with the important thing, take your medication every day to get better. Does that make sense to people? Okay. Visual aids, we didn't give you that opportunity. I hope you have some ability to use visual aids, a piece of paper to draw something sometimes having the person draw something for you to draw their understanding of what they're supposed to do with the syringe or whatever piece of equipment they have to use. I heard question about the living situation and social contact. That's often forgot, especially in my field where we're, it's about your medication and you got to take it and all of that stuff. And then there was the issue about respecting cultural beliefs. And it's hard to get all of that in one encounter. And if it's only a 15-minute encounter. So I'm hoping that you have support within your facilities or your employment agency, that this information is collected for you and available to you when you see your patient. If not, that would be a great thing to advocate for. And then the other one is confirming comprehension. And one of the things that I interviewed patients about their experiences, and their experiences have been really very nice. But one of the things that irritated them was, they'll tell me all this stuff. It's time to close out the interview. And so they tell me what we did. And then they leave. And so it doesn't give me a chance to confirm in my own mind that I know. So one of the things that I think it's really important for us to add is to ask the person, okay, now what do you think we agreed about? Or what are you going to do when you go home? Or what, not just what questions do you have, but have them somehow give you feedback about what they heard. So, you know, what do you think is the most important thing that we discussed today? Some kind of question like that, open-ended question, to get them to tell you what they learned and what they plan to do. So these are the tools that you already have. And I think that one of the things that I want you to know is that you're holding space for people. This is a great, it's such a gift. And we walk alongside them to help them. So the whole notion of culture, we didn't really go into that at all, but here's some information about where you can go to get more information about that. This is a hot link, so you can click here or in the references. And this is pretty much exactly what you do with anybody. It doesn't matter what culture they come from. The issue here is plain language. And so this is a link here to a site that can talk to you about alternative words that you can use for medical language and just more simple language. Okay, so what's washing and polishing? Oh my goodness. It's what we can do now, our plan to think about how we're going to clean the window for ourselves and for others, and use the tools not only that you have, but the potential for other tools that you can gain through various different organizations like the Northwest Education Center. And let me go here. I'm just kind of hurrying along. We live in an environment that teaches us language. It teaches us how to think by the words that we're exposed to. So in our professional literature, there's now organization and information about how to reframe language so that it isn't ageist, so that it doesn't perpetuate negative information about people. And so there's, I don't know if you can see this very well, but in this article, it's today's society is experiencing a silver tsunami or tsunami, which suggests an increased risk number of aged adults and seniors. And look at this, arthritic, suffering from arthritis, suffering, physically challenged with debilitating medical condition. These are all living up to that whole negative stereotyping that we do for older people or people with chronic conditions. So here's a rewrite of that. And notice that it's reframed. And I want you to notice too, that here in this one where it's today's society, silver tsunami, suffering people, the problem is being presented to us as the problem is the person. It's the sick person. It's the person who is old. In this version, when you read this version, you will see that the problem has been redefined. The problem is not the person, but the problem is we lack preventative models and pain management strategies to help us support others. So I think this is really important, and I hope that you are going to be exposed to this kind of language, this kind of problem solving. It's not the person, it's the condition. And then I thought you might get a kick out of this is, you know, we're not, people can be varying ages. And with this culture in our country, now with all the people being let go from jobs, there's a need for us maybe to tune up and turn up our resumes. And so here was some ideas to avoid being age discriminated yourself. And it's kind of a shock to realize that if you graduated before 1995, you better not put that in your resume. You have a degree, that's fine. The whole article is here. It's in the Forbes Business Magazine. It's kind of interesting. I don't know how much research the individual who wrote it did to make sure that these are true across a broader community, but I thought it was interesting. And here, drop old-fashioned email addresses. Really? You can't use Yahoo and some of those other ones? They suggested using Gmail. I wonder if they had stock in Google. And then we as older people, I can say that for myself, is we irritate younger people. And so here are some things that came out about what younger people don't like. And nobody likes to be spoken over. Nobody likes to be minimized by get over it. This one, constantly offering unsolicited advice. This is what we do often as medical providers. You should do this, take this, etc., etc. And so what you've been doing and showed me in your report back from our low cases is that you weren't offering unsolicited advice. You were building a case, showing that you were able and willing to help the individual by finding out, one, what was important to them and what their goals were. So I guess we do this with our kids, but maybe not with our clients. And this is all kind of interesting, not respecting personal boundaries at work. So, an older person just goes out and starts elbowing their way in, I guess. But nobody wants their boundaries disrespected. And finally, assuming everyone is heterosexual. So anyway, these are things that we can avoid. And you already are avoiding these by using your own skills. So here's a list of resources. And here's the Center for Chronic Illness. I wanted to give a little shout out to that. They're a wonderful organization. And right here is the implicit bias test, which has been done by Harvard. It's online. It's kind of a fun thing to do. And you might be surprised about any bias that you might have. And it's not just about aging. There's a whole long list of different kinds of biases that an individual can have. So here's some more. And these are just ideas. I think you probably, knowing that you're coming to Northwest Geriatric Education Center material or places, probably have a lot of already good ideas of where to go. So in conclusion, here's our window. And we've gone over a lot of things that you can do that you're already doing to clean our windows between us and another individual. And I just wanted to thank you because I know it's hard. You are angels, and the work of your heart and the work of taking time to listen. That's what you do all the time. It's your gift to the whole world. So you're cleaning windows, holding space, walking alongside of people. How can it be any better for the rest of the world? So thank you very much. I've left you with my contact information. You're welcome to email me at any time. And then I left a couple of little slides at the end as a bonus for if you go on and you look at my slides. So I am ready to answer any questions. And Anita, do you have anything that you want to wrap up?
Yeah, just I did put the evaluation survey as well as a link to our details page in the chat. And we will definitely be posting these slides on that details page link. Thank you so much to everyone who participated and bared with us as we tried this interactive format, which was very nice.